Everyone, my name is Spencer Carrucciu. I'm a vice president at the Oxyon Venture Studio. Formerly, I was a senior advisor at the Center for Medicare and Medicaid Innovation. Before that, was head of data analytics at City Block Health and vice president of product at Remedy Partners. Today, I'm going to talk through a little bit of a framework for how the Center for Medicare and Medicaid Innovation thinks about bringing value-based payments to different populations and different models. Talk through a little bit of a mental model that I've used as thinking through the different features of different models and how, when it comes to building a new model or applying a new payment flexibility or a new waiver, it fits into the broader universe of CMMI models. So just level setting, the Innovation Center is really focused on three major goals, and that is to improve patient care, lower costs, and better align payment systems to promote patient-centered practices. More recently, the Innovation Center has released a strategic framework for how to think about achieving these goals. And this kind of strategic framework starts at the top with building a health system that achieves equitable outcomes through quality, affordable care, and person-centered care, and then uses these kind of tools or strategies beneath to achieve these goals. So that's driving accountable care, advancing health equity, supporting innovation, addressing affordability, and partnering to achieve transformation. Now, all of these strategies will filter down into various ways in which models will actually be created or implemented. What has gone on in the kind of the past few years of CMMI is a lot of reflection and thinking back towards over the past 10 years of CMMI, what lessons have been learned about why models were successful or why models haven't maybe achieved the goals that we've set out to see them have. So I'm going to talk through some of these because I think they relate in a lot of detail for how do we think models will be implemented going forward, and for any new intervention or new kind of payment system or new population, how might the Innovation Center think about implementing a new model? So first, they acknowledge that health equity needs to be embedded in each model. Historically, we have seen kind of inequitable rollout of models that they've focused in certain areas and not others, or haven't really kind of built with equity as in the forefront. The next, to streamline the model portfolio and reduce complexity. Overlap is a very technical problem within models and actually gets very complicated when looking at the impact that model has. If there are multiple models operating in an area, it's both confusing for providers that are looking to operate on them. But when it comes to actually trying to understand the impact of those models, it can make the calculations very complex. And therefore, the learning that we hope to gather out of these systems can never really come to fruition. The third one is that there really have been tools to support transformation. So a lot of these models require providers to expand their scope of practice, to be able to start taking on risk and doing the activities that can help manage that risk. And in doing so, providers need to implement new technology systems or understand data analytics and the ability to hotspot certain patient populations. And that can be a burden for a lot of smaller independent providers. So CMMI has acknowledged that the ability to provide data, the ability to provide other tools and services that can help providers participate in models is a really important part of thinking through either implementing a new model or transforming models. Next, complexity of financial benchmarks have undermined model effectiveness. These models are inherently very complicated. Either a benchmarking approach or risk adjustment or payment flexibilities are inherently very complicated things. And for providers to understand what they are being held responsible for, how they need to act within them so that they can clearly focus on patient care is a burden. So CMMI is acknowledging that as we think about model development going forward, these things need to be built in a way that is not complex on the participants, both participants being beneficiaries and or providers, but that complexity needs to be done in a way that enables everyone to clearly understand what the incentives are. Again, models should encourage a lasting delivery transformation. While ultimately CMMI models are tests, right? They are testing payment flexibilities. They're testing to see what we might want to implement in broader Medicare when it comes to paying for healthcare. We would want models to encourage long-term lasting transformation within the healthcare system. if it is a thing that lasts for 2 years and once the model ends and there's no more impact, that is not the ultimate end goal of these things. They should all be building on each other to really create the health system of the future that we all want. And next, design of models should enable broader participation. I think this has been a bit of a challenge relating to some of the other points on this slide of both the burden of different tools and services, the complexity of financial benchmarks and models, that has not enabled all providers to be able to access and join these models. That has led to kind of decreased participation as well as potentially decreased results. So I think the combination of a lot of these factors enable broader participation, both on the different populations that these models can affect, as well as the different providers that can participate. So as we think about a model or implementing a new model, there are kind of three major questions that I tend to think about. And this relates a little bit more of like a tactical version of the strategies, more focused on kind of the model implementation and design. But it's really three things. So for a given model, which is a big deal to produce and requires a lot of design, a lot of implementation, a lot of kind of provider burden if they're taking these on, it kind of three questions. And is it scalable? Meaning, do we think this is something that is generalizable? Meaning you can both scale like nationally, that the tools and services are there, that providers are ready to do this type of model, that we can clearly see how this can be something that becomes part of Medicare fee-for-service. And then tied to that, is it generalizable, right? If we implement it in one MSA in New York, does that mean it can implement to a MSA in Texas, right? Do we understand what the specific aspects of the model that make it unique to a specific community or not? And how do we believe that they can then generalize across different communities and ensuring that this model isn't just going to succeed in one area and not be able to succeed in others? And then the last one, obviously, does it improve quality and lower cost? We want to ensure that for all models that we have the clear kind of use case that we can say that this model has a clear theory of change and achieving these more equitable goals. And this ties to the just general wanting to drive broader transformation. Next, kind of taking down a level below. As we think about trying to achieve these goals, both the strategies set by the new strategic direction of CMI, the kind of key, more operational questions that we just talked through on the slide, there are tactically a few set of levers that CMI can actually use to incentivize change or to create a model. These are funding, right? The ability to give providers or other organizations money to implement different interventions or different models. It's capitation, right? It's giving them money in advance on a more regular basis in exchange for fee-for-service dollars. It is giving providers risk, right? That can be shared savings, that can be global risk, but in some way tying a portion of a provider's money to some sort of risk, some sort of kind of other outcome. And then payment flexibilities, which is, can they change how fee-for-service is paid today? So it's still maybe a fee-for-service mechanism, but it is waiving the homebound requirement for home health within a particular waiver, enabling the fee-for-service benefit that exists today, but more flexibility in how it's paid. And ultimately, models are a lot of combinations of these factors laid on kind of a foundation of attribution and benchmarking. So as we think about models, or think about should something be a model or should it be a feature of a model, a lot of it kind of comes down to these factors, right? What is the thing that we are trying to enable or trying to incentivize that we think will drive savings, right? Is that just a flexibility? Is that, oh, we want to pay for this new thing, but we want to pay for it in a fee-for-service way, which we think will have downstream outcomes and drive down savings, but ultimately it's one flexibility. Then maybe it should be something that's part of another model, right? That's a feature of another model. Or is this fundamentally, we want to create a new risk construct and we want to, change the way in which we think about doing a new episode. And that new episode is a new risk construct. Then that may be a new model. But if the risk construct that you want to do is total cost of care risk based on the PCP, maybe this should be something that's a flexibility as part of MSSP. Capitation is similar. Capitation in itself can be a feature of other models, right? Capitation is the testing to see if cash flow or just general incentives changes can drive different improvements or resource allocation. That can be nested as part of a full risk model. That can be part of a more episodic model of testing capitation. And then funding is really a feature again as well of saying, okay, for this given provider set of which this model is designed for, we think that there is actually a large amount of startup costs, that it costs a lot for a provider to implement a new system. And funding can help kind of incentivize or bring providers into the model by giving them some startup costs. So all of these are a lot of different features that can be layered on what is maybe a core chassis of, say, a total cost of care, more primary care focused longitudinal model, or an episodic model, more focused on an individual kind of time period and or condition. And then there's a lot of ways that these can be mixed and matched. And I think historically, when we've looked at the model portfolio of CMMI, what has happened is that the mixing and matching of these we've just created a bunch of new models. And I think the new administration has recognized that can lead to a lot of complexity. So there are other ways to create bigger models and then use these features as ways to innovate. So I think as it comes to different conditions or different interventions that we would want to see kind of brought into a value-based construct, I think the key question comes, is this a feature that should be implemented on top of another model? Or is this a new model in its own right? And I think it comes down to these key questions of, is it fundamentally changing attribution and benchmarking and risk structure? Or are we looking to add a flexibility or looking to add, a capitation or a funding mechanism that can then be a kind of a feature within another model? So summarizing a little bit from the prior of when to think about something as a new model versus when to think about something as an existing model. When we're looking at kind of building a new model, that requires implementing kind of all of the things in model design, right? That is benchmarking. How are you going to measure someone against the benchmark to determine success? How do you do attribution? How are providers signing up for this model? How are patients attributed to those providers? How does that all work? Risk adjustment, right? How is the risk adjustment working to ensure that when it comes to the benchmark, that those benchmarks are accurately representing the risk attributed to the population, which is then attributed to measuring the provider? And then lastly, how are these combined into how do we evaluate the efficacy of this program, both on a quality and cost basis? Right? If we, as we think about implementing or building a new value-based care model for a given intervention, if it is going to have to change these fundamental things because of its design or because of what you're trying to incentivize, that is when to think about a new model. But I think in instances of how we think about keeping the CMMI portfolio tighter, we'll want to kind of drive less of these and more think about how can we use existing models, so existing MSSP, right? MSSP has a benchmarking approach, it has an attribution approach, it has risk adjustment, it has built-in evaluations that have been going on for a while. How can we maybe implement kind of on top of the existing model new features or new flexibilities that can kind of micro test different interventions that we might want to implement? So this can be done in all the ways that we talked through before, right? If we want to intervene new flexibility on paying for some sort of intervention, we can put a benefit waiver inside of a model to enable providers to start to implement that intervention, right? And providers can voluntarily implement that intervention if they believe there's an ROI both on cost savings and improved quality. And then CMMI is able to, in that model, do an evaluation to test, okay, for the ones that have used this waiver versus not, what do we see as the impact, right? But it enables a more micro test without doing fundamental new builds of models, leading to all the complexities that we've seen over the past 10 years. It can be the same with funding, right? Okay, we want to incentivize a new provider group, right? We want to enable more rural providers to enter this model, but we have found that rural providers do not have the budgets to go out and buy IT systems. How can we think about giving an advanced funding for them signing up for MSSP so that they can enter these models, right? It isn't changing anything about MSSP. MSSP is still the same model, but AIM is then allowing more money to be given to these providers so that they can enter. Right? So it's just a feature change, not an entire model change. And the last two, benefit enhancements and payment flexibilities, similarly, right? We want to give more payment flexibilities. We want to enable capitation, right? We want to enable PCP to not be paid fee for service, but be paid monthly PMPMs for their expected fee for service payment. We could do that within existing models. That can be a feature within existing models on top of a four-list framework or on top of another framework. So all of these, I think, have to exist in parallel. But as we think about implementing new value-based payment models going forward, thinking about these things as potential features within existing platforms, I think will be the right framework that will enable faster iteration, as well as more consistent evaluations, and hopefully greater uptake of value-based care models going forward.